Greetings, everybody. I want to trust that you're keeping safe and you're staying at home and keeping social distance. Especially during this time of COVID-19, it is important you do so that we can try to fight this out. It's hopeful that we are going to be back into our normal routines and do what we love most. Welcome to this class. Today we want to look at psychosexual dysfunctions. By the end of this class, you should be able to understand the human sexual response phases, should be able to classify various psychosexual disorders, you should be able to explain the causes of psychosexual disorders and recommend intervention or intervention strategies for clients who present with psychosexual disorders. For us to be able to understand the dysfunctions and disorders, it is important that we learn a little bit about the human sexual response phases. It is because most of these dysfunctions emanate from these phases. And we're going to learn these phases as identified by William and Johnson. And they did their research around the 1960s and 70s. They actually inhabited participants who came to the lab and engaged in sexual behavior with their partners or masturbation. As these partners engaged in sexual behavior, William and Masters and Johnson did observe their behaviors, the way they would feel and react, etc. And they also took physiological measures as these behaviors were being exhibited. Based on their observations of reported of about 10,000 orgasms, they actually came with these 4 phases of human sexual response phases. And the first one is excitement. According to Masters and Johnson, during the excitement period, sexual arousal begins to occur. Usually there's an increase in the heart rate, there's an increase in the blood pressure, there's an increase in the blood flow in the genitals. And because of these activities, it causes erection in males, and in females, the vagina expands and begins to produce lubricants. It is worth to note as clinicians that this process usually involves activities of the parasympathetic nerves. And what does that mean? It means that someone has to be relaxed for this to happen. If they don't relax, then it might cause erection issues or lubrication problems. And that's we're going to look at dysfunctions around excitement. They will be around erection, arousal, and lubrication. So it's important to note that someone has to be relaxed for this to happen. And the second stage is the plateau. And in the plateau, usually what happens is that excitement does not just keep going on and on and on. It reaches a plateau. And this is what we mean by that if there's an arousal reaches a high but a stable plateau. And when the sexual activity increases, it is what is going on to lead to orgasm. So here is basically people engaging in sexual activity, and arousal is high but now stable, because now someone is already engaging in this sexual behavior. And that now will lead us to the next stage we call orgasm. In the orgasm, it's one of the best stages in the sense that, there's the feeling of euphoria, there's an increase in the heart rate, involuntary muscle contractions. This is where human beings do all sorts of things because it's really a beautiful stage. And for that reason, once somebody has had his or her orgasm, then they get into the next stage that we are calling the resolution. In the resolution, I want to call this a state or a phase where someone goes back to a resting state. There's a decline in the heart rate, there's decline in the pressure, etc. And during the resolution, what we usually call in human sexuality a refractory period is experienced by both males and females. And this is what I mean about refractory period. I mean, it is a phase whereby, or a stage whereby, if a male or a woman, male or female, if none of them fires, then they return to the resting place. And for example, if no man is now firing during resolution and during the refractory period, if once a male or a female resolves, then the refractory period is just a resting place, and it means that there might be no firing again until a certain period of time, which could take hours, it could take even one day, depending on the age and many other factors that every human, individual differences that could cause this. So basically, these are the 4 phases of the human response sexual cycle. Again, remember, this is not really the emphasis of this class today, because then we have a whole course on the human sexuality that can take you time to go through each of these phases. Just a summary and a recap to see how most of these dysfunctions actually develop. Remember that sexual dysfunction affects one or more of these phases, and therefore we're going to look at each of them. Now, again, just before we look at each of them, this sketch here just explains how males go through these phases, beginning at nothing, and then the desire comes in, then the excitement, then we have the plateau, and then they have their orgasm, and after their orgasm, they resolve, and they go to the resting state. Again, it can start over after some time. It can just be immediate, but take over some time again, where the resting stage means the body is just back to the normal state that it was in, and that during this period of time, then it could take, hours to days, depending on individual differences. So this is a typical male response cycle. Let's look at women. Now, women begin at low. This is a resting state. Then they get the desire. After they get the desire, they get into the excitement, then the plateau, and one woman could get into orgasm, and after orgasm, they resolve. So there are 2 scenarios of a woman. One is that someone can get an orgasm, and others may not necessarily get an orgasm. Now, for the ones who get orgasm, then they resolve with orgasm. Now, this particular person resolves with orgasm. Now, for some, the phases are the same, but now they don't have orgasm, but they still have a resolution. This is a very normal experience. It doesn't mean that literally everybody must get orgasm and every sexual behavior must lead, or every sex or intimate relationship must lead to orgasm. Not necessarily. However, there are disorders that could also be the reason that the person may not necessarily get orgasm. We just don't want to normalize it and make that, oh, it's obvious that it's okay that somebody doesn't need to have orgasm. No, but we are saying that it is okay that if that is a normal experience, your desire, you went through an excitement, you had your plateau and went to orgasm, it's possible that you resolve without an orgasm. However, there could be people who have various issues around this, and for that reason, they resolve without orgasm, not because it's normal for them, but maybe because they're experiencing few issues that could be affecting them or stressors. Want now to start looking at these dysfunctions, and if you go to this DSM-5, it labels them as lifelong types. So we want to look at various types of these dysfunctions, and as I said earlier, they are actually based on these phases of human sexual response. The first disorders are to do with the desire. Now, the desire is a phase of a sexual response cycle whereby someone has an urge to have sex, and or they have sexual fantasies and sexual attractions to others. So basically, there's a desire to have sex. And some people don't experience this desire. And 2 dysfunctions affect this phase. One is what we call the hypoactive sexual desire disorder, and the other one is sexual aversion disorder. Remember, you need to have a desire. to have sex. What could inhibit this? There could be some dysfunctions around a person that could inhibit them from achieving a desire. And it could either be hypoactive sexual desire or sexual aversion disorder. Now, what are they? Hypoactive sexual desire is simply a lack of interest in sex. There's no pleasure at all. You don't feel like you want to have sex. Little sexual activity, even with anything that could make you have a desire. Now, some physical responses could be normal. However, for some, there could be a deficiency in lack of interest in the activity. So, in reality, a lot of people find it quite tricky to define this because you're just not sure whether this is actually a reality or not. So, that is one. The other one is sexual aversion disorder. And for sexual aversion disorder, it is characterized by a total aversion to sex. It's like, oh, ouch, I just don't like it. I don't feel anything. Even a sexual advance feels sickening. The person feels frightened, and they just don't feel like. Of course, this disorder is among men and women, but it's more common in women. They lack completely a desire, complete sexual aversion. They want really to get away from it because they don't feel like. The hyperactive one is whereby we actually have, even there could be sexual advances, but there's no interest. But this one, even sexual advances are looking more sickening, and the person doesn't really want to engage in any sexual activity, and therefore there's no desire. Now, usually a sex drive is determined by so many combinations. Remember, there's the biological, we talked about some of the physiological, psychological, and etc. But a lot of times, low sexual desires, like for example, sexual aversion, could be caused by socio-cultural and psychological factors, stressors, low self-drive, cultural orientation, past experiences, maybe, traumatic experiences like sexual abuse amongst others. And that could actually make a person's drive literally lose drive completely, or has no drive at all, or very low drive. So basically, our drives are determined by many things. Combination of attractions, biological, which is the psychological, social, cultural, among others. So some of the biological causes, basically, we don't want to get them into every of this detail, is to do with hormones, and this could be one of the causes. Another cause could just be sexual drive by chronic illness, like medication. Someone is taking some of them, and that could also lead to it. Psychologically, stressors like in the environment, anxiety, depression, anger, fear, etc. Socially, the way you have been cultured, the way you've been oriented, some of them could have a problem, and some cultural standards impact on the way we feel or have a sexual drive. For example, some people go through female genital mutilation, and that alone literally drove everything about them into a sexual desire. Trauma through sexual molestation, amongst others. The second category of disorder is to do with excitement. And usually here, during excitement, we said earlier, we expect a lot of changes in the pelvic region. We expect general physiological arousal, increase in the heart rate, muscle tension, blood pressure, and rate going up. And that leads to men getting an erection. And for the women, they get the clitoris and the labia swell, and of course, they get the lubrication. Now, some people could lack excitement. And this lack of excitement could be both in male and female. If there's a dysfunction in the males, we call that male erectile disorder, because we said excitement eventually leads to erection. Excitement eventually leads to women expanding their vagina and having the swelling of the clitoris and the labia, etc., and the lubrication. So for women, they will get what we call the female sexual arousal disorder. It's important to know that excitement is very key in now the next phases. And therefore, if there's no erection, or there's a problem in the erection, or there's a problem in lubrication or swelling or expansion of the vagina and the swelling of the clitoris, then it's going to be quite tough or difficult for the person to engage in the next stage. So let's look at these two disorders. Now, the female sexual disorder. Usually, this is whereby a woman is unable to maintain lubrication or genital swelling during sexual activity. They have the desire, but then they're unable to have this lubrication. Now, this is because there could be various causes that would make a woman not feel aroused. There's a bit of a desire, but then there is no arousement. You don't feel like there's no lubrication, there's nothing. Now, for male on the other side, they are able to attain erection or maintain erection during sexual activity. Some people call this impotence, etc. And it doesn't mean that just because somebody has not maintained or attained an erection, it's a dysfunction. We're going to see that and we've seen this in other disorders. As a clinician, it's very important to always note that it's only dysfunction when it is a distress to this person or the client. It is causing dysfunction in various social or personal or other areas of operations, and therefore the client comes to seek help because it's affecting them. However, a lot of people experience male erectile issues because of just probably common stresses that have happened in the situation. It could be grief, it could be some little issues that they're facing problems. They could just be tired. Many other things could lead that. So you need to really make sure that for you to assess that the person has passed the criteria for this disorder, then it has to also cause a distress to this person and affects this person in various setups that this person has. Now again, erectile disorders result from interaction between biological, psychological, and social processes, and this could affect also how the person achieves the excitement. Some of the biological causes could just be a hormonal imbalance. Some of them could also be use of medication that could interfere with erections. That's why it's important for you as a clinician to do a thorough clinical intake when you have always your clients. And I always emphasize, it's not just about this specific lesson for this today. No, it's every disorder. Once you have client giving indication of the disorder, do a very thorough clinical intake, look at the causes, how long this problem has been there, what might be the problem behind whatever they're going through, amongst many other things, as we have taught you about the clinical intake. So we said that some of them are medical issues, and you could look at them. Others could be psychological, and there will be so many psychological problems that a person can engage in: stress, depression, other psychological disorders, amongst others. So it's important that you just want to know what exactly could the person be facing. And therefore, what are we saying? That these disorders could also come up with, they could be concurring with other, or there could be comorbids of other disorders. So basically, you want to be sure that there are no other factors that are related to these disorders, and you rule out any medical conditions. Socioculturally, there could be many factors tied to excitement disorders. It could be marital issues, it could be the way people have been oriented in their cultural setups, amongst others. The third category of these disorders is on the stage of, or the phase of orgasm. And in this stage, again, we have three main disorders attached to this phase. Remember, during orgasm, what do we say during the description of the phase? Is that there is semen ejaculation, and for women, many other physiological activities happen around here. For example, for women, the outer third of the vaginal walls will contract. There will be semen ejaculation, amongst others. But there are three main disorders in this phase. We have one we call the rapid or premature ejaculation, Of course, male orgasmic disorder and female orgasmic disorder. What do we mean by rapid or premature ejaculation? It's simply reaching orgasm and ejaculation with little sexual stimulation. Just before the people enjoy their sexual relation, the person already has an ejaculation. And we're going to look at some of these disorders. Of course, you also look at age and other factors, because you could be dealing with a very, very young person who is just now getting into adolescence, and this could just be a common problem. So basically, it's important to also look at it. It could be hurried masturbation experience by young persons who are just now getting to the adolescent stages. So it's very important that you make sure that it's not just it's not just a problem, because age is a key determinant as well. About 30% of men experience rapid ejaculation at some time. So we are saying that it's possible that any person could go through a premature rapid ejaculation, not because they have any serious psychological problem. It could just be a very minor stress in the environment, fatigue, amongst others. So it's important you rule out such kind of factors. So there are many causes that could inhibit or that could cause people or some individuals have rapid or premature ejaculation. Some theories or some researchers have suggested that men with rapid ejaculation contain certain serotonin receptors that are overreactive and others that are underactive. And this could be one of the main cause of premature ejaculation. Others say that probably men with this dysfunction experience greater sensitivity or nerve conduction in the areas of their penis, and therefore they didn't really get so much of arousal, and for that reason it didn't give them so much of a pleasure to engage in the sexual activity, and therefore having a rapid or premature ejaculation. We have what we call the male orgasmic disorder, and this is repeatedly inability to reach orgasm at all, or probably sometimes delayed orgasm after sexual activity. So the person may not be able to reach orgasm, alternatively delayed, may after they have given up and said, wow, this can just continue. And for that reason, they just give up. And then they get the orgasm much later. And of course, there are many reasons. There could be because of low testosterone, could be reason of neurological diseases, and probably if there are any injuries like in the spinal cord could lead to this. So assess that. Remember, in the clinical intake, one of the main area of our clinical intake is usually the previous medical treatment or previous treatment or medical observations of etc. Now, in that you need to exhaust that the client has never sought any medical significant medical help, or they've never been having a previous treatment, and especially if it's related to this. And therefore, because you just want to rule out if there's any medical condition, you also want to rule out if there's medication that is implied in this kind of a disorder. Psychologically, again, anxiety, amongst other issues could lead depression, stress, etc. So it's up to you as a clinician to pick out all these areas and just exhaust them so that you know what exactly could be behind it. Because once you understand the cause of a problem, then treatment becomes, or even intervention measures or whatever measures you want to take becomes easy because you understand what you're dealing with. The female orgasmic disorder is just the same, but this again where women delay, or some of women delay, or they have no orgasm at all following a sexual excitement. They did have a desire, they had an excitement, they went through a plateau state, but then they can't have orgasm, or they have a delayed one. Remember that a lot of women may never reach orgasm, for about 10%, but again, there are various variations as we looked at remember we looked at the cycle, and we saw that some women can resolve without an orgasm, which could be normal and there's no psychological problem attached to it, and others may also not. So you just want to rule out that. And female orgasmic disorder is more common in single women than in married or cohabiting women. Maybe because, you know, most of them, because there's no partner and therefore they just have an excitement, and they have an arousal and excitement, and not necessarily have to get to orgasm. Now, it's not mandatory that everybody must have orgasm, as we said, but we are saying that there could be remember, it only becomes an issue if it's causing distress to the person and it's causing them not to function appropriately or well, and therefore that's why we say you just want to rule out that it's a problem. Some of the biological causes of female orgasmic disorder may include medications, as we say, postal changes, amongst others. So rule out any of these. Psychologically, it could just be trauma, childhood trauma, recent trauma, sexual abuse, amongst many other causes, depression and other disorders. So check out and rule out or approve of any of these issues. Culturally, like, as I said, women who go through female genital mutilation, those who have been given negative information regarding sex, etc., that could be part of the cause of the female orgasmic disorder. Disorders of sexual pain, yes, some people experience pain during sex. So, and this could come, we have vaginismus and we have dyspareunia. And vaginismus is basically whereby it is characterized by involuntary contractions of the muscles of the outer third of the vagina, and therefore preventing a woman from having intercourse. So involuntary contractions of the muscles, and therefore preventing someone from having intercourse. And therefore, as a person, if you force intercourse, then the person is likely to experience pain. Now, many causes could lead this. Maybe they have had some past experience of sexual pain. Could be anxiety, maybe this is the first time, trauma, many unskilled partners, amongst others. Dyspareunia, on the other hand, is just severe pain in the genitals during sex. So somebody's having sex, but hey, it's quite painful. And a lot of time, trauma is behind this. Sexual abuse could be behind this, amongst many others. So they have a lot of pain while having sex, and it's really a bad experience because sex is supposed to be good. You have this excitement, you have the arousal, you have the excitement, but then you have a problem when you're having sex. Another category of not necessarily dysfunction, but these are disorders, we call them paraphilias. And paraphilias is usually whereby people who seek help from us usually have unusual fantasies for non-humans, for children, for non-consenting adults, or humiliating themselves or others. So basically, they are unusual because these sexual urges are not normal. One, they're not done with, they could be with non-humans, like objects, any object. They could be now with little children who cannot even consent. They have sex with non-consenting adults, like, for example, people who have physical challenges and therefore they cannot be able to defend themselves, or two old elderly parents who can't even defend themselves. And of course, it could also involve humiliation of self or a partner. If person experiences this with over 6 months, this kind of behaviors of having sex with non-humans or children or non-consenting adults or objects, etc., then they would actually pass for a certain paraphilia. So we want to look at some of them. One of the main paraphilia is fetishism, and basically fetishism is whereby an individual has intense sexual urges or sexual arousing fantasies that involve the use of an unliving object. For example, someone has a sexual urge for someone's underwear or woman's underwear. Someone has a sexual urge for someone's shoe. Someone has a sexual urge for someone's boots key holder, just basically an object. That's what we call fetishism. So we'll look at some of the causes, and basically there are quite several. Some of the causes, according to behaviorists, is that this could be a learned behavior through classical condition, and therefore it's just someone learns it and therefore engages it, not because there's anything or any cause, but just because they learned it through association, or you like my mobile phone and therefore you like it, and therefore it looks like it's something that gives you a sexual urge, and for that reason you associate my mobile phone with a sexual feeling. Transvestic fetishism, on the other word, is where people cross-dress, and cross-dressing, usually you cross-dress in the clothes of the opposite sex in order to achieve a sexual arousal. So for example, a male client who presents with this could be cross-dressing with the underwears of females, and you get, for example, they are living in the same place, and this woman hangs out their underwears on the lines, and then the person comes, steal them, and dresses in them, and that gives them a sexual arousal, sexual urge. Usually, to say somebody is with transvestism, they have to be heterosexual, because there should be cross-dressing of clothing of the opposite sex. Exhibitionism, on the other hand, from the word to exhibit, is whereby people or clients who present with this problem will say that they like exposing their genitals in a public setting. For example, they just flash out. You are in a public transport system, in a bus, for example, seated next to him, then he flashes out his penis, and that's what we call exhibitionism, from the word exhibit. So they show off and flash out their genitals to expose to the people near them. And usually we say the most common way just to deal with it is ignore, because the more you shout and say, oh my God, what is this? This is when the person feels so nice, and therefore they feel like they want even to show you or flash it even more. So you just ignore it, and you find that this works well. Voyeurism, voyage, going for a tour. This is where a person, they get desire or sexual desires by observing people who are undressed or people having sexual intercourse. They can go through and peep through a hole or a place that they can see people having sex. Alternatively, as we're saying, that they could just observe people undressed. They could even put cameras in strategic places so that they can see when somebody is undressing and having shower. This gives them a very high sexual desire. And usually during this time, they can masturbate just by observing, and then, or even by remembering later, oh, I watched that couple have sex, and then they have a sexual desire, and then they masturbate. We have what we call flirterism, and this has to do with touching and rubbing against an unconsenting person. Sometimes you're in a public place and someone just comes and rubs on you. You might just think that's normal. It may not necessarily be always normal. It could just be a person who has flirterism, and that gives them a very high sexual desire and sexual feelings. And this is really something that also we say begins at around teenagehood, and a lot of people are unaware that these people were rubbing because of fulfilling a certain sexual desire. No, a lot of people just believe it was maybe a push, or it was something not necessary. It wasn't really planned. But of course, the person being a flirterist will always be sure what they are doing is because they want to benefit from it. And then we have this pedophilia, and this is, of course, sexual activity with a child. A child, usually a puberty stage child, and therefore it's a huge crime. Obviously, this could definitely some people can go away with what we've discussed earlier, because a lot of times people even don't experience that these people have this problem. But this one, a pedophile, you can't get away with it as long as the law gets hold of you. So they can have It could be pornography, child pornography. It could be watching or fondling a child or having sexual intercourse with a child. And of course, a lot of victims are usually women. And we know that it's a huge, huge crime, and this could land a person in jail forever in terms of life imprisonment. And a lot of times with pedophilia, kids usually know the person. Most of the time, it's somebody really well known to them. A lot of time, strangers are not pedophiles. It is people who know this because they have interacted with this child for some time, maybe begin by giving sweets, beginning by engaging them in activities, etc., until they go to the point of abusing them. Pedophilia is an act of sexual abuse, and therefore it has an excessive punishment. And there could be a lot of causes. Again, sometimes the cause could be past experiences. Maybe the person also was sexually abused, traumatic experiences in childhood. It could just be a social behavior the person has learned through the others, amongst many other causes. Most people with pedophilia are imprisoned or forced into treatment, and of course, drugs, aversion therapy, masturbatory resuscitation, orgasmic reorientation, amongst many other treatments could be offered in helping this person, including CBT and other areas. And just to point out that a lot of pedophiles also have other disorders, so you want to look at other concurring disorders and assess for them. Could be substance abuse, it could be PTSD, amongst many others. Then we have what we call sexual masochism. And for sexual masochism, the individual involves in the act of being humiliated or beaten. And the more they get humiliated, the more they get painful experiences, is when they feel sexually aroused and desire more to have sex. For example, if beaten by a spouse is when they feel they would like to have a sexual intimacy or sexual intercourse with a spouse. And that's what we call sexual masochism. Sexual sadism is people who inflict a lot of time, pain, and suffering on other people, and that gives them the excitement to have sex with these people. For example, they could pinch, they could tie, they could stab, and that actually gives them a sexual desire to have sex with a person that they've infringed suffering or pain. And of course, this is a sadistic person, and it could be also that the people have past experiences of the same, amongst many others. Some of them have underlying feelings of sexual inadequacy. So it's just you to be able as a clinician to pick out some of these problems. So we don't want to dwell so much on this, but biological studies have found that there could be also possible abnormalities in the endocrine system that could also be the cause of sexual sadism. A word of caution is that a lot of these disorders also are strongly influenced by the norms of that particular society, and therefore for clinicians it is important that unless somebody is hurt, paraphilic behavior should not be considered disorders at all in some situations. So it's just you. Let me say this. Always a client presents a lot of time because this is causing them a distress. This is impairing them to function in certain areas, and for that reason, that's why they're seeking help. But just because you picked a symptom earlier, or you pick several symptoms that indicate the person has a paraphilic issue, and it doesn't cause distress or doesn't cause suffering to the person or impairment, then that won't be able to be classified as a disorder. Only until, for example, in situations like when you have pedophiles, you know, it doesn't matter how much, it doesn't cause anything to this person. It is a problem. Then the other area we want to look at is the GID, the gender identity disorders, and this is where somebody strongly is convinced that they are not people of the gender in which they are biologically assigned into, and for that reason they would rather go get assigned to the other gender they feel comfortable in. they feel that they've been assigned the wrong biological sex, and therefore they would want to remove anything or any sex characteristics that is about that specific biological sex and get or acquire the characteristics of the opposite sex. And in most of the time, this disorder is more among men, and a lot of people with GID experience a lot of anxiety, depression. It's a very, and a lot of people really misunderstand clients with GID and think it's just out of this world, they are pretending, it is abnormal, etc. That conviction is very strong, and GID is a very strong psychological torture that you don't belong to that assigned biological sex, and you think you are male or you think you're female, depending on the psychological impact that you're having. And it could appear in childhood and disappear. However, there are so many reasons, or there's so many causes behind this. Some of them, they say that could be biological, for example, genetic or prenatal factors, e.g. abnormalities in the hypothalamus, and of course, many other factors. So, to more effectively assess and treat gender identity disorders, it's important that you look at various factors and you prepare the client psychologically on what this could involve. For example, if they want to be assigned the other gender, it's very, very important. And some of them is from female to male, others is male to female, others is male to female. So yes, there's one we call the androphilic type, and then the male to female, the autogenephilic type. So clinicians have a big role in preparing clients who would want to go for surgery so that they can be assigned for the gender they feel that they are comfortable with. You need to prepare this client appropriately, look at all the consequences, look at all issues involved, and have the client adjust psychologically for the preparation for these issues. So basically, these are the main psychosexual disorders and dysfunctions. And unless otherwise, if you have any questions,